Welcome to this explainer on one of the most fascinating and honestly most destructive mechanisms in human pathology. We're talking about type 3 hypersensitivity. Today, we're exploring immune complex disease. It's this incredible process that sits right at the intersection of our body's defense and its own destruction. We'll be breaking down the exact pathophysiology, analyzing the cellular cascades, and connecting these microscopic events directly to what you'll see in the clinic. To kick things off, I want you to imagine a scenario. What happens when the very antigen-antibody complexes that are brilliantly designed to protect us from pathogens, well, what if they become trapped? What if instead of being efficiently cleared away by our immune system like they're supposed to be, they get lodged inside our tissues and trigger a massive wave of friendly fire on our own organs? This isn't just some theoretical question. It is the fundamental reality of type 3 hypersensitivity. So, for those of you taking notes, and I highly recommend you do, especially if you're prepping for boards, let's define this formally. Type 3 hypersensitivity is a reaction caused specifically by the deposition of antigen-antibody immune complexes in tissues. This deposition, it's the absolute crucial catalyst. Once they're lodged in the tissue, these complexes act like a massive flare gun, recruiting highly destructive inflammatory cells that lead to severe, widespread organ damage. Here's our roadmap for today's explainer. 1. Mechanism of type 3. 2. Complement and injury. 3. Systemic and local diseases. 4. Diagnosis and histopathology. 5. Treatment strategies. And finally, 6. A high-yield review. All right, let's dive right into section 1. Mechanism of type 3, the micro level. The pathophysiology here really comes down to a massive failure of waste management. Step 1 is actually perfectly normal. An antibody binds to a soluble antigen floating in the blood, forming an immune complex. Normally, your body just sweeps these complexes away, nice and efficient. But step 2, well, that's where the pathology begins. When these complexes are excessive in number, persist for way too long, or just fail to clear out, they become a huge problem. And that leads us to step 3. The sheer weight and volume of these uncleared complexes cause them to physically fall out of circulation. They deposit directly into our tissues, which triggers some incredibly severe inflammation. Now think about where these complexes actually end up. Imagine these immune complexes as microscopic, trapped debris floating down a river. And where does river debris get stuck? Right, in the filters. That's exactly why high filtration areas like the kidney glomeruli, the synovial fluid of your joints, the dense capillary beds of the skin, the blood vessels, and the lungs are so incredibly vulnerable. They basically act like anatomical strainers, catching all this debris and bearing the absolute brunt of the damage. Moving on to section 2, complement and tissue injury. Once those complexes are trapped in the tissue, they don't just sit there quietly doing nothing. They initiate step 1, complement activation. The complement cascade acts like a blaring biochemical alarm system. And this leads right into step 2, rapidly attracting an absolute army of neutrophils to the site. Step 3 is the devastating consequence of all this. You see, these neutrophils arrive expecting to fight off a pathogen, but instead they just find these trapped complexes. In this sort of panicked, relentless response, the neutrophils degranulate. They release highly destructive proteolytic enzymes and reactive oxygen species. This literally chews up the surrounding local tissue, causing severe structural injury. Let's zoom out a bit for section 3, systemic and local diseases. The clinical manifestations we see are generally divided into systemic and localized reactions. On the systemic side, where complexes travel widely throughout the blood, we see classic diseases like systemic lupus erythematosus. That's where autoantibodies form complexes that deposit in the kidneys, the joints, and the skin, giving you that classic malar rash. We also see post-streptococcal glomerulonephritis, where complexes form after a strep infection and absolutely hammer the kidneys, causing edema and hypertension. Then there's polyarteritis nodosa, a really severe vasculitis of medium-sized vessels. Now, in sharp contrast to these widespread diseases is the arthus reaction, which is strictly localized. This occurs right at the specific site of an antigen injection, causing acute local necrosis. And this brings us to another classic systemic disease, serum sickness. Notice the delayed timeline here. It doesn't happen instantly. A patient is exposed to a foreign protein, maybe a specific medication or an antivenom. Then there's a distinct incubation period. It takes time for the body to produce antibodies, form the massive amounts of complexes, and for those complexes to eventually deposit. It's only after that delay that we see the sudden onset of fever, widespread rash, severe joint pain, and swollen lymph nodes. Okay, Section 4, Diagnosis and Histopathology. If you're a medical student or studying for the NEET PG, listen up, because these findings are absolute gold. Under the microscope, you are going to see severe vasculitis. You absolutely must look for fibrinoid necrosis. That is a high-yield, massive trigger word for board exams. It indicates severe vessel wall destruction. You'll also see dense neutrophilic infiltration. And clinically, if you run a blood test, you're often going to find reduced complement levels. Why is that? Well, it's because the relentless formation of these immune complexes is literally consuming the complement proteins way faster than the body can produce them. Now, when we turn off the regular lights and use immunofluorescence to look at these tissue biopsies, we see something incredibly specific. The complexes do not form smooth, straight lines. Because they're basically random clumps of debris falling out of circulation, immunofluorescence shows a distinctive granular pattern of IgG and complement deposits. It looks kind of like glowing, scattered grains of sand along the tissue barrier. Seriously, lock that visual and that word granular into your memory right now. Next up, Section 5, Treatment Strategies. So, the crucial point to remember here is that treatment requires shutting down the immune response that's fueling the complex formation in the first place. If there's a known exogenous trigger, like a drug causing serum sickness, the first step is obvious: remove it. To immediately blunt the acute inflammation, we use powerful corticosteroids. But for long-term organ preservation, especially in diseases like lupus or polyarteritis nodosa, we rely on heavy-hitting immunosuppressive therapies like cyclophosphamide or azathioprine. And more, modern medicine is utilizing targeted biologic therapies to interrupt these very specific immune pathways. Finally, Section 6, High-Yield Exam Review. Let's bring it all together. Examiners absolutely love to test this, so if you're taking boards anytime soon, lean in. Here is the ultimate breakdown differentiating type 2 and type 3 hypersensitivities. In type 2, the antibodies are attacking fixed antigens on specific cells. That leads to localized, cell-specific injury, like what we see in myasthenia gravis. But in type 3, the target is soluble antigens floating in the blood. These form massive complexes that travel around and cause widespread tissue deposition and systemic inflammation. Lupus is the classic, undeniable example here. Basically, think of type 2 as a precision sniper rifle hitting a fixed target, and type 3 as a floating cluster bomb. And to make sure you never, ever forget this on test day, here is your final memory anchor. When you see type 3, I want you to think of the 3 Roman numeral pillars as floating complexes. Type 3 equals immune complexes free-floating in the blood and depositing everywhere. 3 equals free-floating. Got it? We'll wrap up this explainer with a sort of profound irony. Antigen-antibody complexes, which are normally a vital part of our immune defense, can become incredibly dangerous when deposited inside tissues. The very mechanisms designed to protect us become the agents of our own destruction. But it leaves us with a pretty critical question. If we can fully map out exactly how these complexes get trapped, are we just years away from engineering a way to dissolve them before they ever cause disease? Thank you so much for joining me today. Keep reviewing these concepts, and as always, stay curious.